Welcome. Thank you all for coming. This is the first of a lecture series that's going to be continuous at the Academy once every 3 months on topics that we think are especially timely and where we can provide accurate information. And I'm absolutely thrilled today to introduce our first speaker on sudden cardiac arrest in youth, Dr. Les Bisson, who is the team physician for the Buffalo Bills. He's also the head of orthopedics at the University of Buffalo. So very, very thrilled to have him here as our first speaker. Thank you so much, Dr. Bisson.
Thanks, Rael, and thanks for inviting me, and thanks for everybody coming to listen on this important topic. So we'll go through a couple scenarios that can maybe set the table for this talk. So September 9th of 2007, Kevin Everett collapses and is completely paralyzed on the field after hitting his head while making a tackle. And I'm a younger man there with my back to the photographer, but that's us sort of attending to Kevin. And this is what it looks like in an NFL game when you put somebody into an ambulance. February 10th of 2008, Richard Zednick gets cut in the carotid artery and is bleeding profusely, basically was going to bleed to death in about 2 minutes. And I was a person that attended to Richard. And January 2nd of 2023, Damar Hamlin suffers cardiac arrest after being hit in the chest while making a tackle. And this is what it looks like in Cincinnati, and the people sort of praying for Damar afterwards and everybody putting him in the ambulance. December 23rd of 2007, Kevin Everett walks back onto the field at the beginning of a Bills game and waves to the crowd and is basically living a happy and productive life. October 10th of 2008, Richard Zednick gets cleared to play in his first regular season game with the Florida Panthers, comes back from that. And April 18th of 2023, Damar Hamlin's fully cleared and returns to NFL football and was practicing today at training camp. And there's us on the sidelines at the Super Bowl. So how do these things happen, right? This is impressive stuff. What goes on behind the scenes, there'll be some questions that will come up. When you see a catastrophe like this in life and limb-threatening things, how do you get such good outcomes? And importantly, can we get to the point where these sort of outcomes are possible every place? So I'm going to talk for a couple minutes about how the professional teams prepare for these types of athletic emergencies. And I really appreciate the invitation and hope that everybody kind of gets this message out, and hopefully we can get to a great place. I think a very important question to ask is, how would we make Western New York, or how would we make any community, the safest place to play sports? We talk about sports safety and our family members, our children. Maybe it starts with the question of, where is the safest place to play organized sports right now? And I would say at a professional sport venue, and especially at an NFL game. Why is the NFL so safe? This is the theme. If you want to remember anything from this, it's trained personnel with equipment following a plan. If you have those three things, if you have people that know what to do, and you have access to some simple equipment, and you have a plan, you can do the same thing as we've done. So this is the personnel at an NFL football game. There's a lot of people there you can see on the slide. There's orthopedic surgeons, there's primary care physicians, there's chiropractors, there's ophthalmologists, there's people watching, what we call athletic trainer spotters, there's training personnel, there's airway management physicians. There's a lot of people, trained personnel, paying attention to what's happening on an NFL field. Doctors, trainers, paramedics. The guy on the left is Brian Clemency. He's our airway management physician. He's a emergency medicine physician. We've got paramedics. We've got neurologic consultants. This is us. This is the Bills athletic and training staff. We're standing by the number 3 after the Damar rescue, when everybody was celebrating things the weeks afterwards. And so you start with trained personnel. The next thing you need is some equipment, and it's fairly simple equipment. An AED. So know where an AED is, have access to an AED, and you can save somebody from sudden cardiac death. In the football world, we need something to get the face mask off, or we have to know how to get the helmet off. But again, don't let that interfere with things if you've got somebody that is in cardiac arrest. We've got a few other simple items, a spine board, again, things to get the face mask and the helmet off, things to secure an airway, but most importantly, an AED, an automatic external defibrillator. And I'm in the habit, they're every place, really, when you think about it, right? You walk into a grocery store, you walk into a school, you walk into a church, there's a lot of places where you'll see a little sign AED. And if you notice those things, that can come in handy. Besides those episodes that I've been involved in professional sports, I've encountered people. I've been running on a treadmill at the gym, and somebody's come up to me and said, "Hey, doc, there's a person that's like unresponsive over there," and we've gone and done CPR on them and shocked them back to life with an AED. I had a person that was unresponsive at the NFL Combines, like not long after Damar's event, and this wasn't a cardiac situation, but again, called 911, got the paramedics there. Like, these things are actually fairly straightforward, and anybody can do it. I'm a sports medicine physician. I'm not a cardiologist. I'm not an internist. I never do CPR unless someone needs it. And if I can do it, you all can do it. I'm a sports medicine doc. I operate on knees and shoulders. If I can do it, anybody can do it. The third piece is a plan, so some sort of a plan. In professional sports, we have a fairly detailed plan. It's called an emergency action plan. We plan out all these different things, and the key is just think through what you would do if something happened. If you encountered a person or you saw a person collapse, what would you do? That's your plan. The plan can be as simple as, I'm going to roll them on their back and start doing CPR on them, right? I'm going to start pushing up and down their chest, and I'm going to call 911, send somebody for an AED. Like, that's a plan. That's an emergency action plan. This is the Buffalo Sabres medical staff. You can see that I've lost some hair. I'm the guy there with like most of the hair gone in that picture, but that's the Buffalo Sabres medical staff practicing putting a person on a spine board and immobilizing them. It's a teamwork type thing, and besides the practicing and the plan, it involves communication, so you talk about what you would do. In the NFL, part of our plan is a pregame meeting. So again, this is the highest level. That would be the safest place, I think, for somebody to have an event, because all the stuff has been thought out, and we have the trained personnel, we've got the equipment, and we have a fairly detailed plan. The plan starts with communication before every game. So the referees introduce everybody. We review our health and safety procedures. Everybody sort of gets introduced. I'm the medical director, head team physician, et cetera, et cetera. We go around a circle so everybody kind of familiarizes themselves with each other. We talk about the equipment. Where's the equipment that we might need? So where's the ambulance kept? Is it going to come onto the field? Are we going to put them on a stretcher and bring them to the ambulance? Let's make sure the ambulance has a way to get out of the stadium so we can't have it parked in. Let's do things like know where the ambulance is going to go. So we review all these different things, all these bits of equipment. And one of the key things is advanced airway equipment and a defibrillator. It's only happened one other time that somebody had a cardiac event in an NFL game, and it was decades ago. But this has been planned for, and there's this equipment around, and then when it was there and we needed it, well, when we needed it, it was there. We also review again briefly that plan. So lots of talking. Where does somebody go if there's a traumatic episode? Where does somebody go if there's a cardiac arrest and a neurologic emergency? Who's in charge? So there's a lot of people there. You always need a general. So if they're like, who's the general if this happens? If there's a code, who's running it? So we are preemptive about that and know that beforehand. And just a lot of information exchange. After Damar Hamlin's event, there was sort of an after-action report, and we do this every time. So this is, again, part of the plan and communication, which is just going over what did we learn in this episode, because each of these things is, it's a lifesaver, it's a limb save or something. So we should figure out what we learned in that event, and then how do we do it better if it comes in again the next time. So that's, the sort of speed overview of how it's done at the highest level. And I would put to you that you can do the same thing, essentially, at every other level, and all these other places can be just as safe. So how do we take what we know at what I would say is the safest place to do it, and how do we bring that down to high school and youth sports? It's the same thing as athletic performance and strength and conditioning training and nutritional stuff. All that stuff is known, and it's used in college and in high school and in youth sports. We should do the same thing with saving lives, saving limbs. But cardiac arrest is the topic here today, so we'll talk about saving lives. It's people knowing what to do. And there's a whole bunch of ways that you can learn what to do. There are certification courses that you can take, but you can also watch YouTube videos and figure out some quick and dirty things to do, right? You don't have to pass a course to give somebody some chest compressions if you encounter somebody that's had a cardiac arrest. There's Good Samaritan laws. If you do anything, it's better than doing nothing, because the person that's in cardiac arrest is dead at that point. You can't make them worse. So Call 911, push up and down on their chest, and you can, and you know, have somebody find an AED, and you can bring them back to life, and they'll be grateful. Trained personnel can include coaches, referees, athletes, family, community members. The most important person in the world to know CPR, if I ever have a problem, is my wife, because that's the person I spend the most time with. So she knows it. She knows it for me. I know it for her and all the other people. Everybody should do that. Then the equipment is fairly simple, right? What's the most important piece of equipment? Your cell phone. Call 911. That's your most important piece of equipment. Everybody has that piece of equipment as far as I can tell. And then knowing where an AED is. And then the plan, again, the plan can be as simple as call 911, start pushing up and down their chest, send somebody for an AED. That's a plan. And then it can get even more detailed. The rehearsal thing is done at the athletic level. You know, the professional level, it's a very sort of protocolized and standardized rehearsal. But the rehearsal at a youth sports event, a 12-year-old soccer game, could be two parents talking to each other and saying, if we see somebody collapse, one of us will go get that AED that we saw when we came by here, and the other one will start doing compressions and, you know, call 911 or whatever. Like, that's a plan, and these things work. So what would success look like? What would it look like if we had that sort of thing throughout our community? And I think it's a very realizable vision. If somebody suffers cardiac arrest anywhere in Western New York, everybody knows what to do, which is start with doing something, and they do it. So it's not, you know, there's the knowledge and then there's the action. And there's a little bit of a freeze, fight, or flight type thing that will happen sometimes in these moments, and people will want to, you know, like, I don't want to do anything because I don't want to hurt them, but overcome that and do something. How would we get there? There's challenges, right? So we don't have a lot of trained personnel, and Lisa's going to talk about training personnel, right, and getting people trained, I imagine. And a lack of equipment, but you got a cell phone, so you've got half the equipment right there, and then just know where an AED is, and hopefully we'll just get more and more of those around. Communication and a plan. And then, like I said, the plan can be very simple. So there are some things that my department is doing, and I imagine that they're happening in Rochester, and I imagine they're happening in a lot of communities around the world. We all felt the power of focus when what happened to Damar Hamlin, right? I mean, I felt it. 30 million people were watching that. My phone blew up and blew up for weeks, most of the time with well wishes and everything else, not asking any information about him, but hope he's okay, hope you're okay, that type of thing. There was a lot of power on the end of that. And people are still focusing on this issue. We can turn that focus into positive results. And that would be, you know, the ideal end. So we've got an athletic trainer outreach program. We're using that to train students and athletes and their family members in the community. We do educational events. We had a tent at Juneteenth where people could practice on feedback mannequins and learn what it feels like to do CPR. A lot of different things are being done. There's a lot of ways to educate yourself on this topic, and I would encourage everybody to do that and then become an ambassador and have other people get educated, because that's, you know, if we want to get to that vision, that's the way to get there. And that's it. There's a web page that we have. There's some things, you know, just hands-only CPR is fairly easy and fast to learn. There's educational videos on the QRS code and all of that. So I appreciate your attention, and hopefully we can all get everybody to a great place. Thank you.
Thank you so much. Dr. Brisson is willing to take questions now if you have any.
Your husband?
Dr. Friedman.
Yes, thank you. So I have two quick and practical questions. First of all, one where Ellen and I have talked about, on a high school level, you might have 5, 6, 7 teams practicing at the same time, right? Where do you put the device that would be most effective? That would be my first question. And the second question is preventative. I mean, yeah, it's great to do all this. I agree, and I would be very supportive of everything here. But how do you prevent do all the athletes, high school level, have to go through or heart test, or is this your talk?
I'm going to talk about that.
Oh, okay, well, forget it then. I'll leave this.
Yeah, so she'll cover that topic. I mean, there are some easy answers to that, but it's going to come into the next talk, it sounds like. In terms of where do you put the AED, well, we should have AEDs within 2 to 3 minutes of wherever somebody would collapse, right? I mean, ideally, each coach would have one. There are logistics involved. If in a perfect world, there would be lots of them that are within, a minute or two of any place that somebody might collapse. Now, obviously, that can't always be the case for every person in the world, but you keep them, you have them available and marked where people tend to congregate. There are some apps and things like that will tell you where the closest AED is. And maybe Lisa will be able to speak to that a little bit.
Just out of curiosity.
What's an AED cost?
Yeah.
About $1,200 for a decent run-of-the-mill one. For a portable one that is standard, about $1,200.
I see.
They're hard to get right now because lots of people want them, right? So there's that focus, and what happens is when there's that focus, a lot of times, during COVID, there was the focus on ventilators. Everybody wants a ventilator, so let's get those. Right now, there's a focus on IEDs, and a lot of people want those. It will equilibrate, and hopefully we'll get to that place where, honestly, the other thing that will happen is when you'll call 911, a lot of times they can alert you to where the closest AED is. In my mind, one of the solutions, right, when you think through something like this, so you call 911, they locate where you are, and there should be some sort of an audible signal and a flashing light from the closest AED. And it's like, wait a second, there it is, it's over there, somebody go get that one. We don't really have that at this moment, but they can tell you where one is sometimes. And also, if you go and get an AED, often as you're opening the little box that the AED is in, that will call 911. So there is some connectivity with these things, but it's a little, it isn't completely standardized yet, and
And it varies in every community.
yes.
Yeah, that's great, thank you, and thank you for coming.
Yeah, appreciate that. Other questions? Yes.
Is there a program anywhere that's working on improving the equipment that the young people wear when they're practicing? For example, chest protectors like a catcher would use. Are there those kinds of things in possibly being researched?
Yes, absolutely. And it's being done at the NFL level primarily. We've got some, this is not a commercial, but if you go to ubortho.com on our webpage, so it's University of Buffalo Orthopedics, so it's ubortho.com. There's a thing that's for patients and about injury prevention. Because of my position in the NFL and in the NHL, I've gotten permission to put different information that we have about equipment into the public domain. And some of that, the chest protector stuff, we don't have at the moment, but we do have very good data on what helmets should be the most protective for concussion, what sort of shoes are the most protective for foot sprains and preventing ACL tears, and what sort of cleat pattern to use for an artificial versus a natural grass surface, that type of thing. Those posters are available right there. You can go on and look at that. I'm not aware of specific biomechanical testing on various chest protectors. That hasn't been something that the league is invested in because obviously it's that just happened to DeMar, and there's concussions and other things that are sort of a more common issue, so they've gone into that. But that would obviously be, I think, a helpful step.
Thank you.
Any other questions? I just want to thank
Yes.
you again. Oh, I'm sorry.
Sorry.
Go ahead.
So you're talking about compressions and how it could be useful at saving a life, even if, it's better than nothing, of course. I was wondering about the idea of resting breaths and how, as previous knowledge, that was the thing that was part of CPR, but it's not really anymore. But in the situation, for example, where you want to CPR for someone that you're close with and you're okay with doing resting breaths, how much more effective is that? And what are your thoughts on that?
So what I would say is generally, if you're just talking about doing bystander CPR, just stick with compressions. You just do the compressions. Hands sort of in the lower half of the sternum, press about 2 inches deep, keep a song on your head like, Staying Alive by the Bee Gees or Crazy in Love. We've all kind of heard those things, so you kind of do it to that beat. And just keep going with that. The effectiveness of rescue breaths versus no rescue breaths in that, I mean, there's, all those things are investigated, but really we're asking most of the lay public to sort of pay attention to the hands-only CPR, and the rescue breaths are, it's a little more for healthcare providers and that type of thing. So I would just stick with, even if you know somebody, if you're just cranking along, giving them chest compressions, and you've called 911 and somebody's looking for an AED, they've got an outstanding chance.
Yeah. Okay, so the rescue breath's probably not the most effective. Just keep it simple with questions then.
Yeah, I would just keep it simple. That's what I would focus on. And there's other, sort of more advanced things that will be done in formal certification courses and stuff like that. But I would recommend just keeping it simple.
Okay, thank you.
Anything else? Great. Well, thanks for your attention.
So I have a little bit of bad news, and that is that unfortunately Dr. Porter, who was supposed to give the talk about cardiac causes, underlying causes for sudden cardiac events in the young, has COVID and is not able to be with us today. Fortunately, or not, I'm a good friend of his and worked with him. I'm a pediatric cardiologist myself, and I worked with him at URMC, and I actually helped him with his slides, so I feel like I can do a decent job filling in for him today. So George wanted to start with the definition of what is a competitive athlete. And when you come right down to it, anyone who's actively involved in a sport where they're training and competing is a competitive athlete. And in the United States, that's an enormous number of people. At the high school level, 8 million. At the college level, it drops way down. There's that pyramid of what happens when you go from high school to college and in the pros. But if you include adults who are involved in recreational sports, we're talking about between 1.25% of the population of the United States. So an enormous number of people are involved in recreational sports. How many young athletes have an event like this? It's rare. It is really rare. Probably an average number would be 0.6 per 100,000 events, and it's per year. That's very rare. It's highest in the age group that we know about, the high school athlete, but the age range that's considered young athletes is 12 to 25. And in NCAA athletes, they say it's a one chance in almost 10,000 during a 4-year athletic career. So that's a significant risk. The male to female ratio is tremendous, 9 to 1. I don't think it's well understood why that's the case. And black to white athletes, 2 to 1. We don't understand why that's true either. And those are all corrected for race and gender. When does it happen? All of these numbers include non-cardiac events, but 70% of them are in practice. They're not during a competitive game, and they're most common in basketball, but also every other sport you can think of, right from the top to the bottom, the things that you think of as least, like figure skating, like my husband hates. Figure skating also has sudden cardiac death. And this, you don't need to read this huge list are all the things that pathologists find to be associated with sudden cardiac death. And I'm going to go into some of them, the ones that are most common in young athletes. So the first would be unrecognized underlying heart disease. And we're going to talk about the two most common, hypertrophic cardiomyopathy and coronary artery abnormalities. And then the second is cardiac rhythm problems, and that includes what happened to Damar, a sudden change in the heart rhythm related to a collision. And then the third thing is myocarditis, and we're going to spend time on that. So this is what hypertrophic cardiomyopathy is. I can't really see this, I'm at a bad angle. But you can see here the blue side of the heart, blood returning from the body and going out to the lungs, and the red side, blood returning from the lungs and going to the body. And in the picture, which is on your left, that's the normal heart. And you see there's a lot of space in the right side, in the left side of the heart, the red side, lots of space for blood to flow in and out. And in hypertrophic cardiomyopathy, you see the walls are very thick. So the space for blood to flow through is restricted. And especially with exercise, when the heart is beating hard and powerfully, that space is even more restricted. So this is the most common underlying diagnosis that was not detected in advance, and it's in 40% of times where we find the cause, that's the cause. The second is anomalous origins of the coronary arteries. Now, in the panel which is on your left, you're looking at a CT scan, and I don't have a pointer, so I can't point. But the left coronary comes out and branches, 2 branches, one down the left side and one to the back of the heart. And the right coronary comes out on the right side and spreads down the right side of the heart. You can see in the diagram how easy it is for that flow pattern to occur. Here you see some of the many variations of the coronary artery pattern that occur where the coronary arteries could be compressed by associated structures, primarily the pulmonary artery, which is in front. Imagine the heart is very full, beating hard, beating fast in the midst of an exercise, and the coronary is compressed, blood flow to the heart muscle is decreased, and you can have a rhythm problem come on, or a sudden collapse just because there's not enough flow. And this is the second most common cause, 19%. Now, electrical abnormalities are the big group that we can't find. At autopsy, you can't find a rhythm problem. You find nothing, usually. And I'm just showing you, I know this is more information than you really need, but of course, I can't resist showing you the normal electrocardiogram at the top, this little panel in the middle at the top, which shows the normal pattern. This little P wave on the left, and then the tall spike, which is the beat going down to the bottom part of the heart, and then the T wave, which is when the heart is recovering, repolarizing, and getting ready to beat again. On the panel on your left at the bottom, you see at the very bottom, you see that line where the spike, 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 regular, narrow, that's the normal pattern. And it's really easy to see. On your right-hand side, you see a pattern called Wolff-Parkinson-White. And this is where there's an extra pathway going from the top to the bottom of the heart. And you can see it if you look closely at where the P wave is there, and then you see the QRS, the beat for the ventricle, there's a little upslope there. And that's a person who's had that kind of EKG has WPPW, and that they're at risk for a sudden cardiac event. And then you don't need to be a cardiologist to see this abnormality, right? You were used to seeing that narrow beat, nice and regular. All of a sudden, the heart has a storm of beats, very fast, irregular. And this kind of ventricular tachycardia deteriorates to fibrillation, to no beats at all, in no time at all. And this is very likely what happened to Damar, where he developed a very fast, sudden rhythm and then fibrillation with no effective beats at all. So this is a well-known problem in youngsters. And I remember in the month before I retired, I did an exercise test on a little girl playing baseball who hit her first home run. She was running from home plate to first base and collapsed. We put her on the treadmill. All of her testing was normal. I put her on the treadmill. Within 3 minutes, she started to have this rhythm. It's a well-known cause, and you can see how it goes back to normal. Sometimes it goes back to normal, and you never know it was there. So this is the kind of testing you sometimes have to do in order to pick up an underlying abnormality. And then finally, of course, we have to talk about myocarditis. This is an inflammation of the heart muscle that occurs usually in response to infection, and it's a rare complication of viral infection. And it peaks in infancy and in adolescents and young adults, and 6% of sudden cardiac deaths are related to myocarditis. So it's a low cause, but it is a definite cause. And COVID-19 is caused by a virus, and we see myocarditis in 2 in 1,000 patients. This slide is in error. It's 2 in 1,000, not 2 in 10,000. Now, there's a lot of discussion, and those of you who heard us talking on Evan Dawson know how many people called in about the risk of myocarditis after the COVID-19 vaccine. And there is a risk of it, for sure. It occurs very, very shortly after the vaccine, very commonly after the booster dose, not the first dose. And again, just as in with the normal virus, it's much higher in males than it is in females. The cases were mild. There has never been a reported case of a sudden cardiac arrest with myocarditis after the COVID-19 vaccine. The risk is, with the virus itself, 2 in 1,000. With the vaccine, 1 in 1,000. That doesn't mean we shouldn't be serious about considering whether to vaccinate a young athlete. And this is data that shows the difference with the 2 different vaccines. The Pfizer has a much higher incidence than the Moderna, and it occurs in a younger age group. The Moderna vaccine occurs in the older age group. So again, those are considerations you can have if you're concerned about having a youngster vaccinated. And I think you have to make an informed decision about whether the risk of COVID is greater than the risk of the possible small chance of myocarditis after the vaccine. And your healthcare provider can give you, I think, the best information about your own kid. So why do we care so much about this? I hate to say it, but I think Damar made me think very specifically about this problem. It's a tragedy when a healthy young person drops. It's a tragedy, and we feel it, and we don't want that to happen. It feels wrong. So there's high-profile deaths like what happened with Damar and what happened just last week with the son of LeBron James when he collapsed playing basketball in the summer, not in a game. He collapsed and was resuscitated. We don't know details about what happened to him, but the media coverage of these events is incredible. So I'm just showing you a couple of things that happened in the last few months. But even this week, the LA Times is reporting that Bronny went out for dinner and played the piano. And I'm thrilled to know that, but you can imagine the intense scrutiny that families are under in this circumstance. And Damar, he's wearing pads in practice. It's headline news here in Rochester. The coverage of this makes us very, very aware of it. And that's one of the reasons, I think, why we pay so much attention to it. So what can we do? Dr. Besson has told us what we can do. We can be prepared. We can be ready to do CPR, and we have to have at hand AEDs, and I think we need to make those way more available than they are now. This is the thing that somebody asked about. I think it was you, Christine. What is the pre-participation screening that we can do to pick up somebody who's at risk? And so there's a lot of discussion about that. Unfortunately, there's no test that you can do that is going to easily pick up every athlete who's at risk. But I'm going to tell you about some of the things that are recommended. 1 in 5 athletes have a condition that could cause a sudden cardiac death event. Not is definitely going to cause it, but has the potential. And of those people, about 40%, an average of 40%, have symptoms that might bring them to attention if they were to offer those up. We also have relevant family history in many people. So pre-participation sports screening is intended to identify those cases. And in New York State, since last year, since 2022, we have the Dominic Murray Sudden Cardiac Arrest Prevention Act. This is in all of New York State. You are required to do a screening for everyone who's going to participate in a team sport. And the screening consists of the family completing a health history, and if that's positive, going for a physical exam, or instead of having the screening done by the family and filling out the form, they can go to their pediatrician and have the form completed there. It's, again, the Heart Association has a 14-point screen that covers the physical exam findings, the symptoms, and the family history, and that's a good thing that people can use if they want to. I'm just going to tell you about Dominic Murray because it's a really good story. He was a 17-year-old boy playing 3-on-1 basketball in the gym in high school when he collapsed. No one did anything. He was there just with his friends. No one knew what to do, and no one did anything. It was in 2009. he was found to have hypertrophic cardiomyopathy. And his mother knew that knew that that was a diagnosis that could have been picked up if he'd been properly screened. So she took up the cause of getting appropriate screening into schools in New York State. That was 2009. 2022, she got it done. This is not an easy thing to do, but she did it. She hung in there, and this is what the law requires. This is the law that requires they have the pre-participation form, that there's an AED in every school, and that there's at least one person who's trained to do CPR. Now, we already know one AED per school and one person trained to do CPR, that's not going to work, right? We have to have an AED for every team, and we have to have someone who's responsible for an arrest to do CPR with every team for every practice and every event. And that's where we're going. That's the movement that we're involved in now. Oh, I want to just go over this for a second because people might have questions about the symptoms that someone might have. And they're just what you'd think. Fainting during, especially during or immediately after exercise. Racing heart, palpitations, irregular heartbeat. Dizziness or lightheadedness during exercise. Chest pain or discomfort with exercise. Excessive shortness of breath, way out of proportion to what you've had before or what anybody else on the team is experiencing. And then excessive unexpected fatigue during or after. Those are symptoms that can help. And I'd say number one is fainting, lightheadedness, or collapse while active. That is something that really should be taken very seriously. And then the second thing would be palpitations. There are all kinds of risk factors that people bring with them. Using diet pills, using these energy drinks, using drugs for other reasons and carrying that onto the field. There are people who go into athletics with hypertension or high cholesterol, not knowing about it and not caring about it. And there are people who have had a provider say, you know, I wonder if that's a heart problem, and ordered some tests. That turns out to be a risk factor for identifying a problem. The family history is really, really useful. And the major thing is if there's someone who's died suddenly, below 50 years of age in unexpected circumstances. So they just dropped, or they fainted, they had seizures, they had a single car accident, they drowned. All of those are risk factors for someone who had an arrest in a situation that caused their death. Any relative, and this is the thing that we ask families, any relative who has an enlarged heart, a known diagnosis of hypertrophic cardiomyopathy, because that can be familial in about 50% of cases. Structural heart abnormality of any kind in the family. Heart rhythm problems in the family. Anyone in the family who has a pacemaker or an implanted defibrillator, or anybody who has, this is separate and I'm not going to talk about it, Marfan syndrome, which is a risk for aortic dissection. What can you do on the physical exam? Not much. The only one of the diagnoses that we talked about that can show up on the physical exam would be hypertrophic cardiomyopathy with a murmur. You can't really pick that up. You can't really pick up any of the other abnormalities just on the exam. Using the EKG, there's been a lot of push for many years to do screening electrocardiograms, but unfortunately, they lead to a lot of false positives and false negatives. So in this country, screening electrocardiograms are not recommended. Bottom line of all this, sudden cardiac events are rare, but they're devastating, and we would like them never to happen. Pre-participation sports physicals and evaluations can pick up people who are at some extra risk and can, in some of those cases, prevent it altogether from happening. But on-site trained CPR and AED provides a dramatic change, potential dramatic change in the outcome of a sudden cardiac death event. Thank you. I'm happy to take questions now. We were going to do questions at the end, but go ahead.
Yeah, I have two questions. They're kind of related to public health. The first one is, I guess I kind of know the answer to this one, but for like kids in grade school participating in PE, do they go through some sort of screening prior in order to be clear to do activities in PE, like basketball, swimming, stuff like that?
At the elementary school level, no. The screening process starts at age 12. Pediatricians do a basic screen whenever they see a child, asking those questions that we talked about. But given all the many things that a pediatrician has to cover, there's not going to be a big focus on that. So no, the risk really starts and really accelerates actually after age 12.
Okay. And then like the second question would be like, how do we like apply this towards recreational athletes that are adults that don't know they have a cardiac issue, go to the gym or the park to play basketball?
You know, I think what we have to have is AEDs that are available in the public. And we were just in London on vacation, and on the street there, attached to lampposts, they have these white packs that have in black letters, huge letters, that you can see from a block away, AED. In central London, they're on every block. That's the kind of awareness that we have to have, and that's the kind of availability that we have to have. We're well behind in this country, but we really need to go for public availability so that every kid and every adult has the potential for resuscitation if something dangerous happens. Thanks.
Awesome. Thank you.
Yes.
It's maybe something I can research outside of here, but in regards to what specifically happened to Damar, I know he didn't have to get any ICD or any type of protective device after that. Now, and they didn't find any electrophysiological abnormality as a sensory pathway or something like
Right.
that. Did they think it was the sudden impact basically causing a PVC at the time of the QRS, or?
Well, I think Dr. Besson could speak to this better than I can, but I think commotio cordis, it's a well-described condition where someone has impact, and it's thought to be impact occurring at the time of repolarization, that T wave, when the heart is vulnerable because the electrical system is kind of in a repolarization condition. But we don't really know, because how often are we going to have a monitor on when someone suffers that kind of arrest? But that's my understanding. You want to add anything to that?
I probably shouldn't because I'm one of his healthcare providers, so I would just refer you to what's in the public domain.
Yeah, but the bottom line is his event was found to be considered a once in a lifetime thing, so that he was cleared to return to full participation. And that's the least common of all the causes that I talked about. It's way, way down. But that doesn't mean I haven't seen it. I did. I did have a kid who was hit with a lacrosse ball right in the center, and another kid, catcher, was hit just below his little padded vest, a baseball catcher, and went down. So
You could see on an event monitor
if they were wearing it,
hypothetically if they're
yeah. But remember, these are people who were at no risk. So they're not wearing anything. But yeah.
Maybe the smart home technology and Apple Watches and that sort of thing will eventually like capture something like that.
wild.
Yeah. That is a really fascinating arrhythmia. And what we know is just what we think.
Yeah.
So thank you for asking. Any other questions? Yes.
With respect to COVID, and if I understood correctly, you said the research showed that the risk inherent to the vaccine was about half the risk of actually getting COVID. Has there been any studies that you're aware of that sort of show trends in terms of frequency of these types of events, like over the last 10 years or specifically during COVID, or that combination of having COVID or potentially
Well, in terms of myocarditis, there hasn't been more myocarditis, except that during the pandemic, we had so many cases of virus at once. But if you look back over time, like our financial guy shows me from 1929, you know, what's happening. If you look back over that period of time, there has not been an increase in cases, except related to the increasing size of the population and the increasing incidence of viral infections because we're all living closer and closer together. Thanks, though. Okay, so now I get to introduce Lisa Neff from the American Heart Association. She's going to talk about closed hands-only CPR, not closed chest, hands only, and the use of the AED. So thank you. Thanks for coming, Lisa.
All right, thank you for having me. So as I said, I'm going to be talking really about hands-only CPR, not hands-off. That's a totally different thing, hands-only CPR. Really, everything that the other speakers have discussed today kind of gives that really big level overview. But now let's shift our focus into, okay, something happens, what do we do? And I'm going to say this probably a few times throughout my talk here, that hands-only CPR is a public awareness campaign. This is not meant to replace a full training. We still encourage you to go take a full course. You're going to learn so much more in a full course about those rescue breaths, about scene assessment, making sure that you don't become a secondary victim on scene. So cannot stress enough the importance that if you have the time and the availability to, please try to go take a full course. And if I do my job today, hopefully I will inspire you to go take one of those courses. Show of hands, who here has been certified or has taken a full course before? Amazing. This is going to make my job real easy today then. Then let's start. Pop quiz. You didn't know you were going to get a quiz tonight. When does the history of CPR date back to? A, 1530, B, 1740, or C, 1960? I hear a B. Who here has seen The Princess Bride? One of my favorite movies. Okay. So 1530 is actually when the bellows method came out. So I have the picture of Magic Man there, you know. He pumps the guy full of air and then pushes down on his chest to make him breathe. That really was the very first start of learning that breaths were important. So 1530. 1740 is actually when we found the compression side of things, pushing on the chest to push that oxygenated blood to all the vital organs. And C, in 1960, is when they finally put it all together into what we now know as CPR, cardiopulmonary resuscitation. And of course, that changes quite frequently too as the science continues to develop. So we talked a little bit, the emphasis on youth sports is critically important. But I do also want to make a note of saying that 350,000 cardiac arrests occur outside of hospitals in the United States every year. There is a very good chance that that is somebody you know, somebody you love, somebody you care about, a friend, or a colleague. Unfortunately, in so many of those cases, people don't know how to respond, they don't know how to act, and they aren't prepared when something happens. I love that you talked about having those emergency action plans. We call them cardiac emergency action plans in our world, CERPs. We want to make sure people have that plan in place, even if that plan is just you knowing what to do. As it was talked about before, it can happen to anyone, anytime. You don't have the ability sometimes to say, oh, I need to make sure I do this, and they happened here right now. What would you do? If I collapsed, what would you do? Thinking about that and being prepared in every situation that we walk into is vitally important. And hands-only CPR, what I'm going to actually, if you go into the other room tonight, you'll get a chance to actually try it if it's been a while since you took that course. It's always good to refresh those skills because hands-only CPR alone can double or triple somebody's chances of surviving a cardiac arrest. And I will say, unfortunately, the outcomes for cardiac arrest are not great. In 90% of situations, people do not survive. However, if you do not provide CPR to them, that chance is zero. So you can only help in so many of these situations. Now, a question was asked earlier about the difference of hands-only CPR and then conventional CPR providing those rescue breaths. So I do just want to kind of touch on it a little bit here. As I said before, hands-only CPR, public awareness campaign to teach people to do something rather than nothing. We want to make sure everybody is prepared. A full CPR training, though, especially if you need it for work where you need to have a certification card, you do need to go take a full course, and there are many different types of classes available. For the average person, we often recommend just a Heart Saver First Aid CPR program. Really good basic course. If you're in the medical profession, you may need a BLS or an ACLS program to make sure that you're doing basic life support or advanced cardiac life support. Those are different classes. But for the average person, a friends and family course or a Heart Saver is going to do the job for you, okay? All right, point number 1 with hands-only CPR. If you see a teen or adult suddenly collapse, you can jump in and make a difference. You can start by, I'll demonstrate later, putting your hands on the chest, dialing 911, and starting compressions. Hands-only CPR should only be used on teens and adults, though. It would not be used on infants or children. Again, importance of taking one of those full courses to learn how to properly provide CPR to a child. If you do have access to a friends and family kit, which I have some in the other room that I can demonstrate, they also make those for infants as well. So again, if you don't need a card, you can still learn how to provide that course. There's some amazing videos online, but if you actually want to practice and put your hands on a mannequin, they make friends and family kits that make it very easy to learn how to do that, especially if you have like grandparents watching little children or something like in that, like that. Second point that I want to emphasize here, calling 911 and staying on the phone. 911 is the first line of defense in everything that we do here. If you see a teen or adult suddenly collapse, whether it's a cardiac arrest or not, they have collapsed, they probably need some sort of medical help. It may not be a cardiac arrest. It may be a seizure. It may be that they passed out for some other reason. They still need medical attention in some way. Call 911. Bystanders, or if you have a room full of bystanders, a group of people, if you are the one to respond and you don't have a phone on you, do make sure that you point at somebody, make eye contact, and say, hey, you, go call 911. Why do we do that? If there's a group of 20 people, why don't we just shout out, somebody call 911? Either nobody will, or the other side of that, everybody will. And when everybody does that, dispatch gets 20 calls thinking that there is a mass trauma incident happening and sends all of their resources, taking them away from other critical needs. So again, it's important to make eye contact, point to one person, tell them what to do. If you're alone, you do it yourself, and you put your phone on speaker. When you are on the phone with the 911 dispatch, give them as much information as possible. If you are the one to come across the scene, if you witnessed it happen, give as many details as you can. I saw the person collapse at this time. They went down. I did this. I called you here. Give as much information as possible. If you stumble upon a scene and you just find somebody down, you give as much information as you can. The other point I want to make clear here, giving your location clearly. I was on a college campus the other day and telling them, how would you tell somebody how to get to this, basement room down in the middle of nowhere with no windows in it? How do you direct dispatch to get to you quickly? And they were like, I don't even know what room we're in right now. How do you really think that through? If you are in your own home, what else can you do to help get 911 in as fast as possible? Is there a quick way you can run over and open a garage door and give them access, or unlock your front door for them? Just try to make it easier and quicker for people to get into you. And of course, there are instructions here for Spanish if need be. But again, the most important part, stay on the phone. Do not hang up on dispatch. Even after you've given your location and called in, stay on the line. Another pop quiz. Sorry, everybody. Keeping you on your toes tonight. And I actually didn't get a chance to research this before I walked in tonight. Where is the closest AED located? Does anyone know?
We're buying one.
You're buying one. I like it.
Under yet. Supply chain.
So that automated external defibrillator, very important device, can be the difference between somebody coming back from a cardiac arrest or not. But if you don't have one, you still make the best of the situation by providing hands-only CPR to that person. We at the Heart Association do not recommend any specific devices. What I do want to say, though, is if you are purchasing a device, please make sure you have called your local public access to defibrillation group that organizes, or a council. Sometimes it's through your emergency medical services. Find out what devices they use, because you can often find a comparable not home device, but not a medical grade device that is compatible, so that when they show up on scene, all they have to do is plug in their pads, and they don't actually have to swap out the pads and do everything else. So step one is making sure your device is compatible, but also step two, making sure they know you have a device. Because if somebody else in that area needs it, they could direct them to you. So just making sure you are crossing everything off and making sure people are aware. AEDs are so easy to use, you do not need to be CPR certified to utilize one. When you see one, if you are in an airport, a mall, a post office, a school, when you see that heart with the electrical bolt, if you need it, pull it off the wall and use it. The hardest part is turning it on, and it's usually a big green button that says power on it. As soon as you turn that button on, it is going to start talking to you and giving you step-by-step instructions of what to do, including take the pads off the paper, put the pads on the chest, and I will step aside here for just a moment. Hopefully you can all hear me. Remember, left lower, right upper. Keep your L's together. Left lower, right upper. When you're doing pad placement though, the pads actually have a lovely diagram on them, and it also really doesn't matter if you flip-flop, as long as, again, the pads are in between the heart, because the idea is the electric pulse is going through the heart, okay? And again, does not matter which device you use, they all have very similar instructions, and they all operate in pretty much the same way. Sadly, in most places, and this is what I find, people don't know where to locate the AED. The one that gets me here, in hospitality industry, 66% of employees could not locate their AED. So hopefully you don't go down in a hotel, okay? In many businesses where I do a lot of these talks, I'll ask people, where's your closest AED? Nobody knows. I tell the safety team they can't answer. It's usually right outside the door where I'm teaching, especially if it's a busy place. Be mindful of that heart with the electrical bolt. Once you've seen it once and you start paying attention to it, you'll be aware of it. And I have the question here. Does your workplace, your organization, your child's sports team have that cardiac emergency response plan in place? If not, we have some tools and resources at the Heart Association. I actually have a sheet on it in the other room that I encourage you to take. It asks some really simple questions about identifying who is going to be your safety team. And I can tell you, it should be more than one person to go through a full CPR training and learn how to use the AED and feel 100% confident in their skills. If you have the AED, making sure that there's proper signage and that EMS has been notified that you have one. And practice. We can't say that enough. We practice fire drills. Why don't we practice other cardiac emergencies? Why don't we practice what happens in a cardiac arrest, a stroke, or a heart attack? If somebody were to go down where you live, work, play, pray, or heal, what would you do? And I always like putting this up here because take a look at that blue arrow. Laypersons are about 50% of the chain of survival when you really stop and think about it. I grew up in a very rural community. My EMS can take anywhere from 20 to 30 minutes to arrive. I could be doing CPR on somebody for a very long time before paramedics arrive, if I have to do it. You can be the difference of somebody's outcomes when they arrive at the hospital, when paramedics arrive on scene, because nothing is more disheartening for paramedics when they arrive on scene and there's 20 people standing around with nobody doing anything. Be the difference for somebody. Can you get in legal trouble for helping? Absolutely not. You mentioned the Good Samaritan law. You are protected as long as you are acting in good faith. You are protected by the Good Samaritan law. Can you make things worse? No. If somebody is in cardiac arrest and you do nothing, they are dead. You have no formal training. What if I do it wrong? I only do 1-inch deep compression instead of a 2-inch deep compression, or I'm doing 90 beats per minute instead of the 100 to 120. Something is always better than nothing. There are stories of children who have saved their grandparents doing CPR on them, and I can tell you they're not getting a full 2-inch deep compression, but they're doing something. They're keeping that blood going. And it's very simple. Just remember the 2 steps. If you see a teen or adult suddenly collapse, call 911, push hard and fast in the center of the chest. I am going to skip over the video here.
If you see a teen or adult.
Maybe? There we go. We do have a full playlist called the Don't Drop the Beat or Be the Beat playlist on Spotify. I will say it's full of bangers. Just go on there. It's a wonderful playlist. It's really good. But I just wanted to put this up here really quickly to show you the steps of practice. And we'll be doing this in the other room, so I encourage everybody, come try it. First things first. If you see somebody go down, hey, can you hear me? Hey, can you hear me? Good hard shoulder taps. Try to get them to give you some sign of responsiveness. If they don't, the next thing we do is look and listen. No more than 10 seconds, though. Ear over mouth, face, foot over chest. You want to see if the chest is rising and falling normally. Sometimes when folks are in cardiac arrest, they may just be gasping for air, and it may just be like a but it's not, you won't see that normal chest rising and falling. So that's why we look and listen. Ear over mouth, face looking over the chest. You want to see if that chest is going up and down normally. If neither of those things are happening, that's when you start looking around your room. If you have people, you, go call 911. You, go get the AED. Sorry, I keep using you. Very good attention. I like it. If you have people, put them to work. Really critical. But if you're by yourself, you dial 911 on your phone, you put it on speaker. And then the next thing you do is you do your compressions. The way that we do these, and I'm obviously not going to be able to demonstrate up here at this podium, so we'll take it to the other room. But I prefer dominant hand out, non-dominant wraps around the top, but whichever way works and feels best for you. We do hand placements this way. We really don't advise doing this way anymore. This, elbows locked, good strong arms. You are a 2-inch pile driver into somebody's chest if you really stop and think about it. So you're up on your knees so you can leverage your own body weight over them, because you want to make sure that you are not pushing and leaning on them the whole time, because that chest needs to be able to recoil. If somebody had told me when the first 3 times I got certified and walked out of the room not knowing a thing of what I had just learned, that all I was doing was manually pumping and beating somebody's heart for them every time I push and release, it would have made a lot more sense to me. Instead, they scared me with compressions and checking the airway and tilt the chin and pinch the nose and all of that in a 4-hour span, and then don't fail your test or else you're not going to get certified. And by the time I would walk out of the room, I'm like, I hope I never have to do that. It wasn't until I started working with the Heart Association and doing this that I'm like, oh, that makes sense to me. So we push hard and fast, right in the center of the chest. So I want everybody to take that hard, meaty part of your own hand, push it right into the center of your own chest. And what do you feel? You're pushing right on that chest plate, right on the sternum. Yep, 2 inches deep. A 2-inch push, okay? It is a hard push. If you do have the people available with you, after 30 seconds of doing good compressions, you're gonna feel exhausted. You'll hear me get winded when I do it out there, and I've been doing it a lot. If you have 2 people, the other person would be sitting on the other side of you, ready to go. You'd go 1, 2, 3, switch, and the other person would take over. Again, no rescue breaths with this. You're simply doing compressions to keep the blood flowing to the vital organs to sustain the person until paramedics arrive, or until you get that AED on scene, whichever comes first. And you keep doing those compressions until the person either regains consciousness, starts breathing normally again, or like I said, extra help comes. So with that, I'm going to stop there. Are there any questions?
This is, oh, go ahead. This is not really a question, but I want to share this because this really works. So I wasn't there, but probably about 10 years ago, in his 50s, my brother, cardiac arrest in home. My sister-in-law heard him upstairs in the bathroom fall. He hit his head. She was going to be recertifying him for CPR and first aid the next day, but she said she was pretty rusty. She went upstairs. She called 911, started the hands-only compressions. The Webster Fire Department came, but she brought him back. And he's fine. I mean, that wasn't really supposed to happen, right? It was at 1 in how many?
Yep.
So I just had to share that because.
Thank you for sharing.
I have a question about drowning.
About what?
Drowning.
Drowning, yes.
Where it seems like the airway might be a more serious thing. Should you still just go forge right ahead with the hands only? And
If all you know is hands only, stick with it. Keep it simple. Just do that. It kind of goes to the question earlier about the difference between the two, and if we're saying like, oh, you don't have to. No, we still recommend rescue breaths, especially in situations where the airway is compromised. And that's still, like I said, hands-only CPR is only for teens and adults. The reason why we don't recommend this for infants and children, besides the fact that the depth of compression is different, most of those cases are respiratory. So it's very important to learn how to clear that airway. And that's why lifeguards are fully certified, because they need to learn how to clear the airway. Mhm. Good question. Same with drug overdose, too. It's a lot of airway. Who's ready to give some CPR a try? Thank you.
Thank you, Lisa. I think this has been great, and I hope you guys have enjoyed it. And I did mention that this is the first of a lecture series. Our next one is on back pain. Totally different subject. 3 months, you'll get information. If you leave us with, we have a form for you to fill out with suggestions for things you'd like to hear about. But also, if you leave us your email, you can get an announcement for that. So, hoping to see you all again. Thank you all so much for coming.